alaikum. I am Naif Al and today I will be presenting the business understanding for our project titled Diabetes Detection Using Patient Healthcare Records. Let's move first for the introduction. So, for the introduction for our project, the diabetes is a common disease that can affect many people. So, if it's not detected earlier, it can cause serious health problems. The early detection helps patients get treatment sooner and live healthier lives. So, it can help support healthcare professionals in making better decisions. For the problem definition, diabetes diagnosis usually depends on the medical tests and the doctor's experience. So this process can take time and may lead to human errors. So at the same time, a lot of patients' health data is collected but not used, but not used effectively for the early detection. Motivation for our project. Firstly, the early detection can reduce severe diabetes complications complications. It helps prevent serious health problems caused by diabetes. The manual diagnosis is prone to human error. It also can lead mistakes due to human judgment. Third, the patient health data is underutilized because a lot of patient data is collected but not fully used for protection. Uh, the objectives of our project, firstly, to develop machine learning model diabetes detection. Second, to analyze patient healthcare records effectively. Third, to improve accuracy and consistency of diagnosis. Third, finally, to support healthcare professionals in decision making. We can assist the doctors in making faster and better diagnosis decisions.
For this project, we used the PIMA Indians diabetes dataset. The dataset is publicly available and commonly used in machine learning research. The dataset contains 2,000 patient samples. There are 8 input features and 1 target variable. The dataset contains patient healthcare records. Each record represents 1 patient, and the dataset focuses on diabetes prediction. The input features include pregnancy, glucose level, blood pressure, skin thickness, insulin, BMI, diabetes, pituitary function, and age. The target variable is called outcome. It indicates whether the patient is diabetic 1 or non-diabetic 0. The first pre-processing step is data cleaning. In the dataset, some features contain zero values. These zero values are not heuristic for medical measurement, for we treat zero value as missing data. We replace this zero value with the median value of each feature. This approach helps reduce the effect of outlier and keep the data balanced. This slide shows the feature selection step. In this step, we selected the most relevant medical features from the dataset. These features include pregnancy, glucose, blood pressure, skin thickness, insulin, BMI, diabetes, pituitary function, and age. These features are commonly used in diabetes prediction. We store the selected feature in variable X. The target variable, which is outcome, was stored separately in Y. We then display the first 3 rows of the selected feature to verify the data. This slide shows the data splitting the data set into training and testing sets. We use 80% of the data for training and 20% for testing. The training set is used to train the machine learning models, and the testing set is used to evaluate model performance on unseen data. The output confirms the split. We obtained 1,600 training samples and 400 testing samples. Each sample contains 8 selected features. The final pre-processing step is normalization. We use standard scalar to standardize the features. This method transforms the data to have a mean of 0 and a standard deviation of 1. The scala is fit only on the training data to avoid data leakage. The same transformation is then applied to the testing data. Normalization ensures that all features contribute equally during model training.
For the feature training part, in this project, we use 8 medical features as inputs, namely pregnancies, glucose, blood pressure, skin thickness, insulin, BMI, diabetes, predictive function, and age. During feature training, we first check the dataset and find that some medical measurements contain the value 0, which is not realistic for real patients and is treated as missing data. So to improve our data quality, we replace this 0 with the middle value of each corresponding feature so that the distribution of the data become more realistic and less biased by incorrect value. So this is before data cleaning. As you can see, there are some 0 values, and then after we data cleaning, we replace this 0 value with median value. For the part 3, which is model development, for the model selection, our system consists of pre-supervised classification algorithm, which is logistic regression, decision tree, and support machine. For the first one, the logistic regression, it is learning a set of weights for each health attribute and applying the logistic function to estimate the probability that is the outcome is one as the diabetic output. And then logistic regression is trained on the standardized training data and then evaluated on the testing data to provide reference performance in terms of accuracy, precision, recall, and advanced score. Like this. And then decision tree is used to model decision rules in a tree-like structure that splits patients into diabetic or non-diabetic groups. Additionally, the algorithm selects a feature and a threshold that best separates the data into fewer subsets. This splitting process continues until stopping criteria are met and each leaf node represents a final decision, which is diabetic or non-diabetic. This the last one is the approximation. It is a margin-based classification algorithm that best separates diabetic and non-diabetic patients in the feature space. In simple terms, FEM chooses a boundary that maximizes the margin, which is distance between the hyperpin and the nearest data points from each class that is called as supervectors.
Now for model training. As you already know, we train 3 models which are logistic regression, decision tree, and SVM. We also use 80% of the data for training and the rest which is 20% for testing. After that, our features were standardized using standard scalar. For hyperparameters, we set some hyperparameters like maximum iterations and class weights to handle class imbalance. And lastly, the goal for our model training was to identify the model that could predict diabetes most accurately. Next, for model evaluation, as you already know, we use 5 metrics to evaluate our model, which are accuracy, precision, recall, F1 score, and confusion matrix. So, based on the result that we can see in this slide, decision tree model shows the best performance compared to the other models. This is because decision tree model has the highest accuracy of 98%, precision of 94.84%, recall of 100%, and F1 score of 97.35%. This result indicates that decision tree model could classify most of the instances correctly and identifies all of the positive cases perfectly. For the confusion matrix of decision tree, it shows the true negative is 245, the false positive is 8, the false negative is 0, and the true positive is 147. For the 0 false negatives and 8 false positives, it explains the perfect recall and very high precision of decision tree performance, which making it highly reliable for identifying positive cases. To conclude this, we agree that decision tree model is the model that could predict diabetes most accurately. That's all for our presentation. Thank you.